Hi, I'm Guy, demonstrating the RSI Sefton OSCE for ILS. We've been called to respond to a 40-year-old male who is reported to have slipped and fallen approximately 6 meters onto a concrete driveway after water blasting their roof. The neighbor who called it in used a Zimmer frame to get around and was unable to assist in any way with the patient, so the ambulance were called. And we have a patient here. They're presenting with decorticate and decerebrate positioning. They are combative, agitated, but they're moaning and groaning, so no words that make sense at the moment. They are holding their breath, and from what I can tell, in just approaching the patient, it seems a little irregular. Being unable to see anything untoward, hear anything, or smell anything toxic, judging the scene safe to approach and assess the patient. So Hannah, I'm going to get you to do a set of vitals for me, please, just while I do the primary survey. So, looking into the patient's airway, there's nothing obstructing it, it's patent, self-maintained. Check the breathing, get low. Okay, so the patient is definitely breathing, but yeah, I can confirm it's irregular, roughly 12, but I'll get you to confirm that if that's okay. Checking for a perfusing rhythm, pulse. Okay, we're getting good radials. They're a little Brady, but not necessarily bradycardic. I'm happy this patient is not in arrest just yet, but I am concerned. I'm just going to do a quick trauma sweep, blood sweep. Okay. Okay, I can see something on my gloves just from the occiput, so it's a head wound of some description. Checking the shoulders, exposing the chest. Checking the axilla. Reaching behind, feeling the spine if I can. Nothing there. Nothing on my gloves. Okay, being alert for any moans and groans from the patient as I palpate. Pelvis, there's nothing there. Doesn't seem to have fractured the pelvis. I can't see any shortening or rotation of the legs, but I will be mindful of any injuries given the mechanism of injury and the high amount of kinetic energy this patient would have had when he hit the ground.
Okay, so his vital signs have come back as 160/90 BP. His heart rate was 50, and his rest rate counting now is 12 and irregular.
Right, okay.
His BGR was 7.6 and his temperature was 37.
Okay, so just reassessing the trauma sweep, the occiput has got some definite bogginess behind it. So judging from what I can find and no other injuries, I think this patient has landed on their head. I suspect a traumatic brain injury, especially given the hypertension, the low pulse rate given that hypertension, and the irregular rests. So because of the low GCS, did you get a GCS at all?
Yeah, I did get a GCS. So it was made up of 1, 2, and 2. It would make up of 5.
Thanks. Okay. GCS of less than 9, irregular rests. I think that this patient is status 1. So Hannah, I'm going to take care of the airway. Can I get you to call for backup, please?
No problem.
It's important in RSI to start preparing early and maintaining the airway because that's probably what the patient is going to lose control of most rapidly. So just putting the patient in a sniffing position with a handily placed towel already there. That's well maintained.
Okay, so backup's on their way with RSI skill, and they request that you start preparing for RSI because they're 10 minutes away. Okay,
are they happy to meet us en route?
Yes, they are.
Excellent. So, for the extrication of this patient, we're going to be very mindful of the C-spine, and we're going to take great care putting them on the scoop stretch and then onto the striker for the ambulance so we don't compound the damage already done and cause secondary injuries. We put towels either side of the head and neck to maintain that, hold on to their clavicles, and I would have a bystander ideally, or my offsider if no other bystanders present themselves, just on that duty alone. I would try and stay away from giving this patient a C-collar, given their agitation and the imminent loss of their airway. It's going to be quite important to have access to it, and I think they would fight the C-collar. So in this instance, I would prefer just to have the towels for now. If I've got the time, I would take these towels in place just to maintain that, and we can get rid of those in a hurry if we need to. Before we set off, I'm going to cannulate this patient bilaterally with some large bore cannulas, ideally 16 gauge, in anticipation of needing fluid if their blood pressure drops. So I will also task my offsider before we start moving with preparing an IV bag we'll definitely have to check that. I would also preemptively draw up morphine to treat the patient's agitation as well as sedation pre-RSI. And I will be very mindful to drug check the morphine with my offsider. After drug checking the fluid and morphine, I will task my offsider with driving, as it's imperative we get to definitive healthcare rather quickly, and we will meet our backup en route. So, continuing on with my RSI checklist, I'm going to use the St. John Pocket Guide as a checklist to make sure I haven't missed anything. Pre-RSI, it's very important that we oxygenate this patient as best we can, aiming for 100%, as the patient is likely to desaturate once we administer the paralytics and insert the laryngoscope. The patient is maintaining their own airway at the moment, breathing, if irregularly, but what I'd like to do is insert an OPA in order to help maintain the airway. So I'm just going to measure that up, insert that, and I'm going to attach an acute mask at 10 litres per minute. In addition, I'm also going to attach some nasal cannulas, not on oxygen, but during the RSI procedure. This will be helping the patient remain oxygenated as best we can. Should the patient vomit, I'll be prepared to roll them onto their side, remove the OPA, and I've got the suction at hand if we need to get rid of any vomit, just in case they aspirate. Running through the preparation for RSI checklist, it's also good practice to attach the ETCO2. In anticipation of the ETT tube being inserted into the patient, I'm going to put a Thomas tube holder under the neck now, if it's safe to move their neck. And I'm going to prepare a bag valve mask. On the bag valve mask, I'm going to attach a peak set at 5. This is in order to increase thoracic pressure, therefore increasing the effectiveness of ventilations and the oxygenation of the patient. And I'm going to set that aside for when it's needed. I'm going to take a second set of vitals and a 12-lead ECG and update the ICP en route to meet us with any changes in their status and tell them when to meet us.